Well, good morning. Thanks, guys, for agreeing to answer some questions for us about medical direction. For those of you who don't know, at least on my screen at the top, we have Dr. Bill Worden, the founder and chief of Heartland Medical Direction. I don't even know how many years ago you started, but I know in the last 3 years it's grown tremendously, which caused us to bring on an associate medical director or affiliate. I don't know what the exact term is. We just call her Dr. Wells.
Hello.
She's bottom of my screen. Both have a background in EMS prior to becoming physicians. And so they kind of have both views of what medical direction looks like from the field and then from the field as a physician medical director. One of the cool things about Heartland Medical Direction is all of our physicians are active in the field. And when I say active, they show up. I remember Dr. Warden put on a 12 lead for me a couple of years ago on a dirty street road in Altus, Oklahoma. And so I haven't had that pleasure with Dr. Wells yet because I'm in an aircraft and we have kind of limited space. And so, but our physicians do get out and do things. It's not like the check boxes on, your end of the year paperwork anymore. So it's pretty fun to get their opinion on some things. So I have a couple of questions for you guys, if you guys are ready.
Yep.
Let's do it.
So
Let's go.
can you tell me what even is medical direction to begin with? Let's talk about that. What is medical direction?
So I'll start and then let Dr. Wells chime in. Obviously, there's regulatory and statutory requirements for medical direction that says an ambulance service has to have a medical director. And a lot of times that medical director is quite honestly the wizard behind the curtain that nobody ever sees. Somebody signs your paperwork when you renew your paramedic license every 2 years. Somebody checks that off and you have no idea who that is. And that unfortunately meets the requirements of being a medical director. I think I have a different philosophy, and I think Dr. Wells agrees with that too, is that the medical director needs to be active. The medics need to feel comfortable calling the medical director, talking to the medical director, debriefing calls. The medical director ought to be in the field running calls with their medics, and they ought to be out there teaching. So I think that we have a different philosophy than most places do. Would you agree, Dr. Wells?
Oh yeah, absolutely. I think it's important to kind of stay in the world with the people that you're directing and kind of know what's going on out there and, stay active.
So if somebody were to need to reach out and get medical direction,
Mhm.
how can they do that here?
So they can obviously just reach out to us at one of our phone numbers, or our website has a contact form on it, and that's www.heartlandmedicaldirection.org. And quite honestly, that's how we've gotten most of our agencies. Is somebody's reached out to us and said, "Hey, somebody told me about you, or I heard about you guys, or I've seen what you've done." And so we're always glad to help other agencies because we think this is important to build, a big system across the state so that everybody works together.
It's kind of like one team sort of thing. Everybody working together is a lot better than everyone working against each other for
Yeah, and
sure.
everybody has the same protocols. We know the same things. We're taught the same things. So if we all show up on a scene together, we're able to do things basically the same way.
Can you kind of explain to me maybe your role as a physician as far as providing guidance to pre-hospital medical professionals that are non-physicians? How does that work? Say I'm a paramedic. Say I'm on a call and I've kind of reached a point where I've decided that hey, maybe it's best if I consult the medical director on this. How would I do that?
So we have an online medical control recorded line that you can call that's accessed through the protocol app.
Mhm.
And they can call that number at any point and it'll ring to either Dr. Warden or myself or one of our paramedics with the OMD. And we can kind of help the medic through the situation that they're in, kind of come up with maybe some alternative options for how to treat the patient or what we can do with the patient, maybe some medication orders that are outside of the protocol but would still be appropriate, or even just kind of like help with disposition for the patient. Like, is it better to have an intercept called? Is it better to have an aircraft called, or are they safe to go by ground? Um, and then also for refusals, we help with those as well. And sometimes we help talk with our patients who aren't necessarily sure they want to go to the hospital but might need to go.
Sure. And I think that's probably a big thing, especially with rural EMS, is just maybe having, I think it pays a dividend to have an interactive physician medical director because you don't have exposure to as many calls. So your volume's not as large. And so you may end up in a situation in which you're uncomfortable because you're unfamiliar.
Yeah.
And so if if I call that line, kind of walk me through like what would happen. You said that, one of you two will answer in most cases, right?
Yeah, absolutely. So, the way they get to the one of us is through the protocol app or just having that number. And that number is 405-876 7211. And that gets the recorded medical control line. The thing is, what we would both like is start off with, hey, this is Jayton. I'm a paramedic at Ambulance Service XYZ. I need to know if I can give Cardizem, and then tell me about the patient. That way, that entire time that you're giving us the history, the information, we're thinking about, okay, is this patient appropriate for cardizem? Is there another medicine? Whatever the case may be. But that way, we're in the same train of thought as you are, because you've called knowing what you want to do, trying to get permission from online medical control, but we don't. So if you start off and tell us the history and the medicines that are on and the things you've done, then we're not real sure which direction you're going. So it's better to start off with, hey, I'm a paramedic, I'm at this ambulance service, here's what I would like to do, then tell us the history.
Mhm.
Why is it important, like for their location, where they're what ambulance service they're with?
Well, I think for two reasons. One, we geographically know where these places are at, and so we kind of understand if their transport time is going to be 10 minutes or an hour and 10 minutes, and that may change our decision, or it may change the decision as to, well, no, let's not do this. How about we do a helicopter intercept, or we change this? And we also somewhat know the capabilities of all of the ambulance services in that the things that they carry, because some rural ambulance services can't afford to carry all the fancy equipment that the major metropolitan areas have.
So as a physician medical director, you're not just taking into context clinical cues from patients, you're also taking in all the logistical requirements and equipment and all those things as well to make your decision.
Yes.
It sounds like maybe that's harder than med school, trying to think about all that stuff at once.
Yeah,
So,
Sometimes
you,
in the middle of
you
the night it can be.
you have to know the map of Oklahoma. It's like when you watch the weather, you have to know where Pushmataha County is and Eakly, Oklahoma, and all those things.
sure, yeah, absolutely. Tell me, is there ever a situation in which the two of you would be unavailable to answer that call?
Yeah, sometimes. The way that it works is when you call that number, it rings first to Dr. Warden's phone, and if he's unable to answer it for whatever reason, then it circles to my phone. And if I can't answer it, then it may go to another paramedic's phone with the office of the medical director. So it's a paramedic that's trained and has been credentialed for this and is fully capable of answering these questions. But if we're both on the phone already, because that does happen
Mhm.
sometimes where multiple people are calling, or say we're at work and we just can't answer the phone because we're in with a sick patient or something like that, then it may go to one of our paramedics. And sometimes if we miss the call, we just call right back.
Mhm.
So it's pretty rare that you won't get anyone.
Okay.
Yeah, and Jane, I think that's important to point out is that even though that there are some paramedics that answer the phone, and you yourself may be a paramedic that's calling, we've taken the time to credential the paramedics at the OMD, so that they understand how to take med control calls. They understand their limitations as to what they can and can't do. And both Dr. Wells and I have verified that. I mean, we've done a written test, we've done a credentialing test. So we're comfortable allowing them to answer those questions. And if at any time they can't, then they try to call one of us, because like Dr. Wells said, there's times that we're both in a patient room or we're both on a phone call, and 2 minutes later we'll be available. So I think that's important to know, is that one, if you're in the field, you're not going to be left alone. Somebody's going to answer the other end of that phone call.
So pretty much, if I want to do a fasciotomy, I need to wait till both of you are busy and get permission from one of the paramedics. Is that
I'm reasonably sure they're not going to give you permission, but you can certainly try that. Yeah.
okay?
YouTube pulled up on one phone and the OMD on the other phone, so you can see how to do it.
It would be a good test
Life is
for
like a
this.
IKEA furniture. You just put it together with instructions.
That's right.
What about if no one answers? What if say it rings and there's not even a paramedic at the office of the medical director available at that time?
I mean, so that's certainly a possibility. And so then two things. One, you would always revert to calling the receiving facility. At most ambulance services, that's what they do because their medical directors aren't online. And so you simply call the receiving facility and ask for orders. The second thing is you wait 60 seconds and you call back, and chances are at that point somebody's going to get it. I mean, we've all got our smartwatches, so we see if we're in a patient room, we see that call's come through, and if it rings again immediately, chances are one of us is going to be free to answer that again.
Okay. So one of the biggest things I think, especially well, as a paramedic who's using diagnostic tools in the field, which we know point of care ultrasound will be a new thing coming out soon, but we've had EKGs available, 12 lead EKGs available
Mhm.
for paramedics for a long time. What if I'm a non-paramedic and I don't have the ability to, clinically diagnose what's going on with the patient to provide some type of treatment? How can I tell you over the phone what that's like without you seeing it? Or is there an avenue in which I can send that to you?
Yeah, absolutely. We can get pictures of EKGs texted to that same medical control number, and it comes up in the app that we use, and we review those in real time. So when that picture of an EKG comes through, it as like a text message essentially. We look at it and we can respond, no, that's not a STEMI, or yes, that is a STEMI. And we can call that number back and talk to the medic and give some direction if needed. Um, but it does come and shows up. But it shows up on both of our phones. So sometimes
Mhm.
you might get two responses that say the same thing, and it's not a
We
glitch.
hope
It's
they say the same thing. We've joked about that we hope
we
we
do.
hope both answer the same thing.
Yeah.
So what's some of the most important information that you would need if I say I call you? We kind of addressed like, hey, I'm Jayton, I'm a paramedic with XYZ service. Kind of what do you want me to tell you what's going on with the patient? Um, like, do you want
Well,
history, like they have back pain, but their toe pain's clear? Like, I assume you want pertinent negatives, like if they have chest pain but no jaw pain, things like that. But what's kind of the flow of information that can make this an easier handoff? I know that time's kind of the essence with a lot of these,
mhm.
and so it's a way that we can make this a better system.
I would say start with who you are and what your level of credentialing is. Like, are you a EMT? Are you a paramedic? Are you
Right.
advanced? Are you whatever? So that we know what you can and can't give as far as medications go. Then tell us what your question is. Hey, I need you to review this EKG, or hey, I need to know if I can give ketamine, or hey, I want to know if I can sedate this person, and then tell us about the patient and try to keep it as concise as possible. This is an
Mhm.
85-year-old female who is complaining of chest pain that started an hour ago. She has a past medical history of stents and AFib. We don't necessarily need to know all the little details like, well, she was walking down the street and then she was walking her dog and the neighbor startled her and then she started having some chest pain. It's just not quite as pertinent. Um, and that way we can get to a helpful decision more quickly for you. And then also, like we said, sometimes multiple people are calling us so that we're not on the phone for an extended amount of time when somebody else might be trying to call in.
Yeah, and I think a lot of the times once they've asked the question of, "Hey, can I give some ketamine?" that may prompt us to ask two or three questions, and then we're done. We don't need any more information. So if they put their question at the beginning, it's going to help us direct that. We don't need the full hospital report that you're going to give when you call in. I mean, most of the time with most of these things, I'm okay with you saying their vital signs are normal. If there's an abnormality, then tell us, but I don't need to know that their blood pressure's 120 over 80 and their heart rate's 80 and they're breathing 16 times a minute. If their vital signs are normal, tell me that. I don't need to know all the information. Now that I would say that's a little different going back to the EKGs that we talked about, earlier in transmitting the EKGs, because on those really the reason we get those EKGs transmitted are kind of twofold. One is to help you determine is that a STEMI, because that helps determine your destination. And then the second thing is, again, based on your geography, are we going to recommend an ALS intercept? So if we're simply interpreting an EKG, we really don't need a lot of information. It's either going to be a STEMI or not. And if it's not, then we may call you and say, hey, what exactly is going on? You may need to request an ALS intercept or divert to this hospital or something like that.
Yeah. I do want to know what vital signs are. If they're good, then just say that.
Right.
But if you're asking for medication, permission to give certain medications or what dose you should give, it's very important to know that either the vital signs are good or if they're not, what they are. And then
Right.
also if it's a medication that needs a patient's weight to calculate the dose, then
Yeah,
knowing
it's important.
what the patient's weight is or a rough estimate of that is also very helpful.
Okay. Yeah, that makes sense for sure. Um, can you tell me, uh, like what's the most frequent call, or what are some common calls that you would receive, just for, if I didn't know anything about medical direction and you were explaining it to me, what's the most frequent calls that you get from the field?
I would say we get pretty frequent calls about field termination
Mhm.
of resuscitation efforts. And also we get frequent calls about refusals. Um, and then we get the handful of calls about patients who don't have DNR paperwork, but the family is saying they're a DNR and can that be honored? Um, things like that. Uh, I would
Yeah, and
say,
the termination one's probably a big one. You know, that's one of the things that we do with all of our agencies. A lot of ambulance services historically transported every cardiac arrest, whether they got ROSC or not, they transported. And so, the studies tell us that it's better to work that cardiac arrest in the field and not move them until you get ROSC. But in the cases where you don't, then we terminate. Of course, the protocols allow even a basic to terminate if they meet certain criteria. So if you meet those criteria in the protocol, you absolutely don't have to call. But on the flip side of that is you're always welcome to call because I understand that if you're the basic in, Nowheresville, Oklahoma, you've probably never terminated a code on your own. And so it's a little mind-boggling to do that without talking to the doctor or something. So we're always okay to take that information and help you make the decision whether to transport or terminate.
absolutely.
So a lot of that seems like it's relatively, I mean, from your perspective, it would seem relatively common because you're answering these calls more frequently than maybe somebody who's working those calls in the field because
Right.
you have a number of individuals who's licensed under your protocol. But for you, what would you say would be one of the most challenging types of patients to provide direction for without physically assessing the patient yourself?
So I think the big ones are the ones that we get that are refusals that you can tell by the history and the vital signs that they're sick. Something's going on. They're hypotensive, tachycardic. The medics think they have a fever, whatever the case may be. But the person is, of course, alert, answering questions, has the capacity to make their own decisions, but just does not want to go to the hospital. I've tried talking to these people on the phone. I'm sure Dr. Wells has done the same thing,
Yeah.
but you can't see them, you can't touch them, you can't put a stethoscope on them, you can't do those kind of things. So all you can really do is talk to them and try to convince them to go. And at the end of the day, if they still refuse, I mean, that's obviously their choice to refuse those calls. So, I mean, we hate that. We hate that they're not going to go to the hospital. We always try to ask a family member to take them to drive themselves, whatever. But those, I think, are probably the toughest ones.
So we kind of talked about just a little bit earlier. We had mentioned that you will get certain calls more frequently, um, whether that's field termination or refusals or anything like that. Do you do you take this information and do any type of quality assurance or any type of training in the field with clinical providers later on, uh, due to those types of calls that you get? Like if
Yeah,
you get a
so
rash of calls for, um, say, tourniquet placement, do you augment that into your training
mhm.
schedule to kind of address those?
Yeah, and so one of the things as an example this year, I think one of the big topics we get is, and I'm going to use the terms consent and capacity. So we'll get a lot of calls about can they refuse their alert and orient times four, but they don't understand what's going on, et cetera. So that was a very frequent call, and it continues to be. So this year at the Heroes in the Heartland conference, we had an EMS attorney provide a lecture specifically over consent and capacity. So if we see something that ultimately needs training, then we're able to do that. Another thing that we've instituted that is hard for a lot of the smaller agencies, but we've done some training, is pit crew CPR. Because we know that with pit crew type CPR, there's an increased likelihood of gaining ROSC and survivability. So we've started instituting some training along those lines as well. So we try to pick up on the major themes and then develop training. And then we also go back and listen to some of these calls, pull the charts and review them to make sure that what they said is what's on the chart and what we told them is what's on the chart, and that type of thing. Because again, all these calls are recorded for quality assurance purposes as needed.
So if I call and I receive medical direction from either of you two or one of the paramedics from the office of the medical director, is there a understanding or an expectation that I, as the patient care provider, will annotate in my narrative of my chart the orders received?
Yeah, absolutely. You should document that, spoke with Dr. Wales, who advised to give TXA for whatever. Because a lot of the times the reason you're calling is to do something that may not be in protocol. As an example, there I use the example of TXA. In our protocols, that's for basically hemorrhagic shock. But there are dozens of other uses for TXA that I'm sure you've seen on Foam Frat or the other blogs or those types of things. That's all outside of protocol. So if somebody's reviewing your chart in the QA department and they see that you used TXA soaked gauze for a tooth bleed, that's outside of our protocol. So you should document, spoke with online medical control, Dr. Wells advised soak a gauze in TXA and place it on the tooth. Then the QAers know that, okay, this is outside of protocol, but they received a permission to do that.
Okay. Do you currently, or if you don't currently, do you think it would be beneficial to include in your simulation trainings a live medical direction call?
So we've done that on some of our simulations, but not all of them. So obviously, one of the things I think about a lot of simulations is everybody survives. And so that's how you pass the simulation. Well, that's not realistic because not everybody does survive. I mean, cardiac arrests die every day, traumatic arrests die every day. And so some of our simulations are terminated at the end when the patient dies. And so perhaps that could initiate an online medical control call. We did that with our sim games, right, Dr. Wells? I mean, that was part of the sim
Yep.
games is online medical control.
Yes.
I like that you said that because that's one of the biggest training scars I feel like when I was a brand new paramedic that I had the worry of losing a patient
Hmm.
after doing everything correct. Because when you go through school, as long as you do everything right, the patient lives. Well,
They
in the
all
real
live.
world, that's the case, you know. That's really cool that you guys incorporate that with your simulation training. That this is as realistic as we can get it
Hmm.
without actually shooting somebody in the leg and dragging them into the trailer and having a tourniquet on. So, just kind of changing gears here a little bit. Not so much of the like the hard and fast rules, but like some personal questions. What's something that you wish that every EMS provider understood before they contacted online medical control? Whether it be something clinical
Whew.
or understand all's going to go like or
Dr. Wells has to
that.
answer this one first. I don't know. Let's see.
Man, that's a hard question because I feel like every call is a little bit different. Even the ones
Uh-huh.
that are pretty standard, there's always some different detail. I
Well,
think
let me.
I think it's important for the medics to have a good understanding of our protocols
Uh-huh.
before they call, and to know how to implement our protocol app, because I think that usually is able to answer most of the questions that they would have in the field. Um, but I guess I don't really know how to answer that question
Yeah,
otherwise.
I mean, I would agree with that because a small percentage of the calls we get are questions that stuff that can be done based on protocol that you don't need to ask permission for. It's just simply in the protocols, whether that's a switch of pain medicine or give additional Zofran or whatever. Some of the questions that we get are in protocol. And so if you just flip to that page in the PDF file on the protocol app, it would have answered that for you.
So, kind of piggybacking on that, what would you say to maybe an EMS provider who's watching this, who works for an agency in which you provide medical direction, who may be hesitant to call for online medical control because they feel as if you assume they should know this at their level of licensure.
Yeah, and so one thing I would say, and I try to teach this when we do our classes, is never assume you know anything. I mean, either look it up if you can or call and ask. I would rather take 1,000 calls a day about what the dose of epinephrine is for anaphylaxis versus you give the wrong dose and potentially cause harm to somebody. I mean, I think you're right in that, yeah, it's in the protocol app and maybe it's something you should know, but in the heat of the moment, we all get flustered and we forget those things. And we don't know where to find it. So I would much rather a medic call every single time to confirm something. And I've actually said on the phone on a call, okay, take a deep breath, calm down, let's walk through this, so we can help figure those things out.
Yeah, I would second everything that you said, and also just encourage any medic that works with us that we are doing this because we like this job. Like we enjoy doing medical direction. I'm never going to be mad that anybody calls. Dr. Warden's never going to be mad that anybody's calling. It
Unless
doesn't
it's
matter what
Jayton. I
time
might get a
it
little upset if Jayton calls.
is. Jaden, you can always call me.
Yeah,
You know, I will.
We don't mind at
not
all.
at all.
We would absolutely prefer for you to call and be sure about what you're doing than to make a decision and do something and then question yourself and have that kind of mental distress
Right.
that we've all experienced at some point over, did I do the right thing? Did I not do the right thing? Getting some backup is always a good idea, and we're never going to be upset about it.
Yep. Completely agree.
So for maybe new people who are new to the umbrella of Heartland, or maybe you're a new EMT or a new paramedic, or maybe you've been on for a while, but you work in a rural area and you do 50 calls a year, so you're not well experienced. What what would be a reasonable, or maybe I should say, what's kind of the expectation for when they would contact medical direction or anybody for that matter? But like, when do you expect them to
I
call?
mean, I think that's a unanswerable question because I mean, the possibilities are endless. I mean, I get calls, and I'm sure you have too. I get calls when I can hear the sirens going and they're on their way to a call, and it's hey, this is an overdose of drug XYZ. What should I do? I get calls when they're on the scene. Hey, Granny doesn't want to go to the hospital, but there's a power of attorney. I mean, we get calls en route. So I mean, it's anything from a medication to a treatment. Do I splint this? Should I call poison control? I mean, if you can think it, we've probably received a med control call about it, and if we haven't, it's certainly okay to call us.
Okay. So, I just know, from personal experience as a brand new paramedic, I had roughly 10 years in EMS before becoming a paramedic, but it felt like it was a whole new thing at that point.
You have a
And,
whole new bag of stuff, things to do.
Yeah.
and there was a feeling, that was just kind of always hanging over me on shift of, oh, I'm going to get into something I haven't ever seen before, something I
Right.
can't, I'm not prepared for. And with time that kind of eases up, you maintain ABCs and do the best you can, and ultimately come to the realization that you're not going to save everybody. And so in those early years, it's really hard to know, like, hey, when should I call the doctor? And is it okay to call the doctor for this or
Mhm.
that? And that's one thing I've always appreciated when working with agencies that are, under the umbrella of Heartland, is just that ease of access to medical direction, being able to call for the simplest of thing or the most complex of thing, and having somebody there on the team with you to help you discuss what's going on with the patient and find an alternative if an alternative needs to be found. Or maybe I just forgot something that, I would have remembered on Tuesday, but today's Wednesday.
Absolutely.
So I got just two more for you, and they're just personal questions again. And this is for both of you. So what's the most rewarding part of providing online medical control or being a medical director in general?
I think for me, the most rewarding part is uh, seeing medics um, doing good work and learning confidence in the work that they're doing, constantly improving, and kind of in our own way, making the world a better place.
Yeah, I mean, I would agree with that. I think, I'm sure we both get frustrated at 2 a.m. when we've gotten 6 calls and we work the next shift. or work the next day. But it's just that knowing that we made a difference. You know, the our hashtag is we saved a life today. And we talk about that and we post it on our stuff, and that really is true. I mean, even this video will potentially do that. It doesn't mean that we necessarily touch somebody and physically save their life today, but because of the things we do, whether it's these online medical control calls, whether it's the training we've done, a class we did, something that we've done for or with an EMS agency or with an individual paramedic, or dispatch or law enforcement, the other things that we work with, at some point in time that person's going to save somebody's life.
Yeah.
1% better every day.
That's right.
So last one for you here, and I guess it's kind of personal, but not maybe not as personal as that. But do you personally have a expectation for crews to call you back, maybe even on your personal line after receiving medical direction and the call's cleared to let you know how the call went? Do you ever have any lingering thoughts about, man, I wonder how that patient turned out, or is my crew okay if it sounded like a pretty devastating thing, you know?
I won't say that I have an expectation, but I will say that there are times that I say, hey, call me when you clear this call and let's talk about it. And then I always want to let the crews know, and I think Dr. Wells is the same. They're always welcome to call us on the non-recorded line to debrief a call. Whether they've called med control or not about it, you know, if it's just something that they want to rehash and think through and think, did I do this right? Could I have done something different? Should we have done whatever? It's always okay to call us afterwards and we'll debrief that with you.
Yeah, and I would say for me, I haven't actually had too many calls where I felt like I needed to say, hey, call me after and let's debrief. But there's been a ton of calls where I was just curious about how it ended up. And so I would separately, text the medic from my cell phone number later when I know that they're done and just ask, like, hey, how did it turn out? Do you think that that medicine worked okay? Was the patient all right? Do you have any other questions? That kind of thing, just for kind of my own closure on the situation. And a lot of medics have my number now, and sometimes they'll call me about things and sometimes they won't. But I do have some curiosity sometimes, and I
Mhm.
just will text them.
Yeah, I think being an EMS provider, one of the things that always kind of gets us is the curiosity of what occurs with the patient after, we
Yeah.
drop off, like the follow-up, like, and sometimes we get that information, they were discharged 3 days later, or, they didn't make it out of the ER. And those are always tough, but um, just kind of knowing and closing that loop for whatever reason, there's that curiosity inside of us as humans, and it makes us wonder, did I do the right thing? Did I contribute to the positive outcome, or was there anything I could have done to, it's better?
Mhm. All
Well, I
right.
think, yeah,
No, so we have one last question. So now tell us from your perspective, because I think you have worked at an agency that didn't have good online medical control. You've now worked for agencies that have good online medical control. And I think you're actually credentialed to take some of those online medical control calls at the end of the day. So give us your perspective about what a medical director and med control should be.
well, so first off, I was not told this was part of the deal.
Tries.
We're the
Well,
boss, so we get to do this.
I will oblige. Yeah, I've worked when I first started in rural EMS in Oklahoma. My agency took about 80 calls a year. We expanded that when we started taking transfers the next year. I was in a very rural place in a very rural county. And so, as you can imagine, there wasn't a lot of experience there. Most of the
Mhm.
providers that were there before I were there for 20 plus years, and they all left in that 2 year span. So there was just a few of us. So we're all green, fresh out of school, no real clinical experience, and then no real field experience. And I had a medical director who I had never even met until the next year when it was time to get paperwork signed again. And in fact, I didn't meet him until it was time to pick that paperwork up. And just by happenstance, he happened to be in his office because when I called to drop it off, he was a family practice physician, and I just dropped it off with the secretary. There would have been no no way that I could have contacted this medical director, and no slight at him. I mean, that's just the way the system was.
Mhm.
He was doing the community a service by providing a necessary element to for them to maintain an ambulance, but he just wasn't involved. He wasn't excited about EMS. It wasn't his thing. And so I would have had zero help. And then, as you well know, in rural EMS is where you need probably the most help, because there's a lot of challenges that rural providers face that aren't necessarily faced by individuals who have a 5-minute transport to a level one trauma center or a level one, stroke designation center or whatever.
Right.
And I've worked for agencies that have had involved medical directors that weren't Heartland Medical Direction, and those were fun. They would come down and do, annual training, but they weren't necessarily available to contact by phone 24/7 when you had a patient. And then when I started paramedic school, I worked in a rural BLS service in Oklahoma that you were the medical director for, and then you came
Oh
over to
no.
a that I was at. And the difference just kind of between not having any access to, getting to do some annual training to now I have a medical director that we can call 24/7. And then you've actually rode some calls out with us on different, hitches that I've been on. Uh, I wasn't joking earlier. I don't know if you remember, but you did put a 12 lead on for me that one time. You jumped in the back, said, "Hey, what do you need?" I said, "He's got chest pain. We're taking care of this. Could you put on a 12 lead?"
I
And
can do some skills. 12 leads, IVs on occasion. I mean, a few things.
I don't know if I would have had you do the IV,
I've
just,
even stolen some crikes from some medics in the field because I was able to get them intubated when the medic wasn't. So
oh
we
Lord,
won't call out names, Blake Braden.
he probably remembers. But yeah, I think if you're an EMS provider and you're working at an agency that doesn't have involved medical directors, maybe have that conversation with them and see if that's something that they're, willing to do is be more involved. Because it really is a force multiplier. When you can pick up the phone as a, pre-hospital professional, whether you're an EMT or a paramedic, whether it's day one or day 1,000 for you to show up at work, you're not going to know everything. And maybe the physician you talk to may not have the exact answer right then, but they're able to deduce some kind of outcome based off of prior experiences that were similar. And so if you don't have that level of involvement, I highly encourage you to have that conversation with your physician medical director and see if that's something they're willing to do for you.
Yeah,
And if not, then, look for alternatives. It may be that, your medical director was never asked to be a part of that, or maybe they're not interested in fulfilling all those responsibilities.
sure.
Uh, and not for a sales pitch, but I do think that we have the best product in the world. I often say that. People ask me, they said, "Well, what is Heartland, or what all does Heartland do?" And there's no way you could summarize it. I mean, from QA to simulation training, and we discussed this earlier. Calls that frequently happen get put into simulation training. Calls that we pick up in QA get put into simulation training. They also get presentations made, and we travel the road with the instructor pool that we have, and we deliver that
Right.
information. Because if you have the question over here in the southwest part of the state, chances are somebody in the northeast part of the state also has the same question. And so, from my perspective as as a staff member at the OMD, I really believe that it is one team, one mission to, hashtag save a life. And everybody works towards that, whether they're working in QA or they're working in training or, God knows the millions of tasks Kinsley does all day. And so it is a nonstop thing. And I do appreciate there's times where I've contacted both of you guys when I'm on the flight line as well. Hey, I've got this, coming down the pipe, and I'm not real sure about this. What about trying this med instead? And so it's nice to be able to have that. Everybody thinks that once you become a paramedic, you know everything. And once you become a paramedic, you realize you don't know anything. And so it's a lot easier to kind of have somebody to help you with that. And then as somebody who's answered those calls before, most of the ones I've answered are about field termination. And of course, we double check the algorithm to make sure that, nobody has forgotten any of the necessary steps to perform that procedure, because it is a high stress thing. You get there and maybe family wants one thing and the patient wanted another thing, or maybe there's a complex set of, scenario that revolves around this cardiac arrest. And so we often forget things unless we have that cognitive offload ability, which is, why we have the RSI checklist at Heartland, because when you're in those high stress situations, you just can't remember everything. So we try to go down that algorithm, make sure that, they've thought of everything, and then ultimately help them to make the best decision for the patient, with as much dignity as possible while staying within legal bounds of making sure nobody gets in trouble for anything. So
Well, thank you. So I want to just add at the end here that this is something we're going to try. I think we're going to try to do a talk a month to start with, whether it's a question and answer like this, or whether it's one of us doing a lecture, so to speak, or not necessarily a lecture, but talking about a topic for 10 or 15 minutes. So, if you're watching this at the end and there's something you'd like to hear from us, shoot us an email and let us know. You can send that to any of our emails. There'll be a tagline at the end to send an email to. But we're going to try to be a little more visible via social media as well so that we can answer some of your questions. So hopefully you guys learned something here. Hopefully, if you want to order the shirt that Jayton's wearing, we'll sell those at the next Christmas party, right?
we could put them in the store.
Yeah, we'll put them in our store or something. So, any parting thoughts, Dr. Wells, Jayton?
No, but I do want to thank both of you guys for all the things because it's unimaginable the amount of tasks that have to occur on a daily basis in order for Heartland Medical Direction to provide the level and quality of service that it does to not only EMS clinicians, but just to maintain the safety and security of Oklahomans and people traveling through our borders. Because it's, you know, emergencies happen to everybody. It doesn't
Right.
discriminate 1 day old to 100 years old, and being able to have that level of training and confidence and our skill set to do the necessary things that we need to do, and then when we're at the end of that and we can't figure anything else out, being able to contact either of you and just have that extra layer of security. From my perspective as a field clinician, there's just no other way that I could ever operate anymore.
Good.
So I just wanted to kind of reach out and say thanks for that, for sure.
Well, thank you. All right. Thanks, guys. We'll see you on our next video.